Hello everyone, welcome to NG's Corner for Nurses. Hope all of you are doing well. In last video, we have already discussed about the types of burn injury and the different degrees or classification of burn injury. In this video, we will discuss about the management of burn. This video will cover the collaborative management of burn, including medical, surgical and nursing management, along with the burn center referral criteria. Criteria for referral to a burn unit includes second and third degree burns greater than 10% total body surface area in patients younger than 10 years and older than 50 years. Second and third degree burns greater than 20%, third degree burns greater than 5%, burns to face, hands, feet, genitalia, perineum and major joints. Electrical burns including lightning injury, chemical burns, inhalation injury, patients with pre-existing conditions, circumferential third degree burns to extremity or chest, and burns involving concomitant trauma with a great risk of morbidity and mortality. Example, explosion trauma. Let's discuss the management. Whenever the patient comes to us, the first step is assessment. So we will do first the primary survey as per the advanced trauma life support guideline. First is A for airway. Early recognition of airway compromise followed by prompt intubation can be life-saving. If there is soot in the mouth, consider early intubation even if the patient is breathing normally. Next, B for breathing. Determine if the patient is moving air or not. C for circulation. Obtain appropriate vascular access and a monitor device to control heart rate and blood pressure. D for disability. Detect if there are any other manifestation including fractures and deformities, abdominal injury or neurological deficit. E for exposure. The patient should be completely exposed and should be out of clothes. Exposure of all orifices must be conducted in this part. F for fluid resuscitation. This is a mainstay in the burn management. We will discuss this point later. Next, coming to the secondary survey, it is a burn specific survey. We will obtain history regarding the time of injury, possibility of being a medical legal case like abuse or not, then the ample history. We all know what is ample history. A for allergic history, M for medication history, P for past medical history, L for last meal when patient taken, and E for events and environments of burn injury, like how this burn injury occur and is it occur in a closed space or an open space like this. Next, we have to do a rapid physical examination to know the GCS score and the vital signs. Then the estimation of extent and depth of burn injury. This is the most important step in burn management. According to the extent and depth of injury, we will manage the patient further. And these things, how to estimate the burn percentage and what are the characteristics of different degrees of burn. In previous videos, I have explained all these things. Please refer those videos. Links are given in description box. Then we have to check for the presence of additional injury and we have to check the body weight and height of the patient. Next, coming to the laboratory investigations, ongoing pulse oximetry and cardiac monitoring are performed for all patients with significant thermal burns. Routine laboratory studies obtained in such patients generally include complete blood count, electrolytes, blood urea nitrogen, creatinine, glucose, venous blood gas or VBG, and carboxyhemoglobin. Next, arterial blood gas, chest radiograph and an electrocardiogram are obtained in any patient at a risk for inhalation injury, and blood cyanide concentrations may be obtained for diagnostic confirmation in this type of patients. Assessment done. We will start oxygen if there is moderate to severe burn or decreased level of consciousness or any signs of respiratory involvement or burn occurred in closed space or there is a history of carbon monoxide or smoke exposure. We will assist in ventilatory support if needed. Next, coming to the fluid management and catheterization. Fluid replacement is done promptly on the basis of total body surface area burnt and the body weight. The most common formula for fluid replacement therapy is Parkland formula. I have already given video on Parkland formula where I have explained the fluid replacement calculations along with examples. So please refer that video. Link is given in the description box. Next is catheterization. Patients above 20% burn need catheterization to monitor intake output chart accurately and to monitor the fluid balance. Next, coming to the drug therapy. First is tetanus prophylaxis. Tetanus prophylaxis should be updated if necessary for any burns deeper than superficial thickness. Next is analgesics to relieve pain. Next is antibiotic prophylaxis and topical antimicrobial agents. Patients with extensive burns are considered to be immunosuppressed on the basis of altered neutrophil activity, T lymphocyte dysfunction, and imbalance in the production of cytokines. So, bacterial colonization of the burn scar site can result. The burn also destroyed the physical barrier to tissue invasion, which permits spread of bacteria to the dermis and through the lymphatics. And once the invasion occurs, organism can proliferate, especially in necrotic tissue, and can invade blood vessels, producing a secondary bacteremia. Therefore, prophylaxis against infection with antibiotics is given to all patients with non-superficial burns. Next is H2 receptor antagonists. Acute upper GI erosions and ulcers, especially the Carling ulcer, may occur in patients with severe burn injuries. The common clinical findings in such patients is painless GI hemorrhage. Treatment of acute stress ulceration is principally preventive. H2 receptor antagonists inhibit gastric acid secretion. This prophylaxis against acute stress ulceration is initiated immediately after admission. Next, coming to the wound care. Wound should be cleaned with normal saline. Dead and loose skin should be removed. Wound may be kept open by applying antimicrobial agents, which is known as open method, or may be covered with sterile Vaseline gauze, and if needed, sterile dressing to be applied to absorb the drainage and to protect the wound, which is known as closed method. Let's see the advantages and disadvantages of open method and closed method. First is the advantages of open method. Visualization of wound, easier mobility and joint range of motion, and simplicity in wound care. And what are the disadvantages of open method? It increases chance of hypothermia from exposure. Next, the advantages of closed method. It decreases evaporative fluid and heat loss, aids in debridement. And the disadvantages are mobility limitations, prevents effective range of motion exercises, and wound assessment is limited. Commonly used topical antibiotic is silver nitrate. Hydrotherapy is used to facilitate cleansing and debridement of the burned area with normal water or normal saline. Debridement is done along with showering, and non-viable tissues can be removed daily during wound dressing. Let's discuss some procedures to treat the wound. First is debridement. Removal of foreign material and devitalized tissue until surrounding healthy tissue is exposed. Next is escharotomy. An incision is placed laterally in case of circumferential burn in limb or in chest to relieve pressure and to prevent vascular compromise. Next is fasciotomy, a cut made in the fascia to relieve pressure and increase blood flow in case of circumferential burn. Next, coming to the burn surgeries. First is flap reconstruction. Flaps are a full thickness section of skin that is surgically removed from one part of the body and placed to another part. Next is skin grafts. A graft is surgically placed on a deeply burned area or to cover an open wound. It is done when wounds are deep or extensive and spontaneous reepithelialization is not possible. Next, coming to the nutritional management. Adequate nutrition is important to assist in wound healing. Extra calories and proteins are needed to combat the loss during injury and to heal the wound. These are the calculations depending on which calories and proteins are calculated. Patients more than 20% burn, placing nasogastric tube and evacuation of fluid from stomach prevents vomiting and aspiration, and it also helps in starting early feeds. Depending on the condition of the patient, total parenteral nutrition also can be administered, and vitamins and mineral supplement also should be given. Next is physiotherapy and psychological therapy. In physiotherapy, positioning, breathing exercises, different stretch exercises, active and passive exercises should be done. And psychological support should be given to the patient and patient's family members, and psychiatric referral should be done if needed. We can divide the post-burn care in different phases. We will discuss the nursing management depending on those phases. First is emergent burn care at the time of injury to 48 to 72 hours. In this phase, the nursing managements are initiating emergency resuscitation, orienting family members, initiating prescribed therapies, monitoring physiologic responses, initiating measures to prevent complication, and providing emotional support. Acute burn care 48 to 72 hours after the injury and continues until wound healing is completed. In this phase, the nursing managements are managing burn wound, providing pain relief, providing nutritional support, monitoring for complications, providing emotional support, and planning for rehabilitation and discharge. Next, rehabilitative burn care begins with closure of burn wound and anticipation of return to the home environment and ends with return to the pre-burn level of activity. Here, the nursing managements are providing skin care and wound management, providing a physical exercise program, scar management, and providing social re-entry. Here some possible nursing diagnoses are given. Please go through it and prepare nursing care plan by your own. You have given care to burn patient in your clinical posting. I would like to know which nursing diagnosis you have prepared for your patients. Please mention it in the comment box. If this video is useful for you, then it is requested to put a like and share it with others. And for getting more videos like this, you can subscribe my YouTube channel or follow my Facebook page NG's Corner for Nurses. And for any queries or suggestions, you are most welcome to comment. Thank you for listening.